Well, Kirk, I appreciate you taking the time to be with us today.
Definitely.
You're the Chief Technology Officer of Wellcentive, and a local company here in Atlanta. And the company has an interesting founding story. Could you briefly tell us about that?
Yeah, absolutely. Two brother-in-laws. We're really talking over Christmas drinks. One of the brother-in-laws was Dr. Paul Taylor, and he was producing reports in Excel for payers, trying to summarize his own quality using claims data. And it was just way too cumbersome, very difficult, and inaccurate. And the other brother-in-law was working at Patient Care Technologies, was a software designer, and they realized, hey, this is a trend that really needs to happen. Physicians need to be paid on quality long-term, and there's absolutely a market here. They stayed small for 4 or 5 years, invested a lot in the product, delivered real results to significant customers in the Michigan area. And I joined about 3 years ago, and I had a unique history that followed along with their path as well. I worked at MedQuist and Immodal. There I saw 20 terabytes of rich text files of pure narrative, and we said we have to tap into that information. But natural language processing and the different contexts that you might look at that narrative text in offered many challenges that I felt would take a long time to really get to the value that I wanted to get to. So I then looked at a company called Outcomes Health Information Solutions, and what they did was they literally put nurses on site, picked up a paper medical record, scanned it, uploaded it to another bank of nurses that would read the paper, and then essentially abstract the information to answer a specific question that a payer would have. And payers would pay $80 a chart for that process to happen. It was a mess, an absolute nightmare of a workflow that led to lower data quality and higher costs. The whole time I was there, I said, can't we get this data directly out of the EHR? And lo and behold, 3 years ago, I found this company, Wellcentive, that was working on exactly that.
Well, that's a great story. In Lesson 10, we'll talk a bit more about feature selection out of natural language records, and I guess these nurses were the first generation of technology for doing that.
Yeah, absolutely.
So let's segue forward to today. Today you're gathering data from lots of doctors' practices and EMRs. Can you give us those numbers?
Yeah, we have about 1,000 practices, 8,000 physicians. We have over 2,500 interfaces pumping data into our data center every day. We process about 200 million data points, clinical data points every month. And one of my favorite stats is that we have sent 178 million transactions to payers that have resulted in a value-based reimbursement payment. And it's all based on clinical quality.
Okay, that sounds like a lot of stuff from a lot of sources. How do you do it?
That's easier asked than answered, but it really comes down to being aggressive with respect to seeking out the data. So that means that for our customers, what we need to do is we need to go to them and say, you know what, I don't care what format of the data you have. Your system exports data somehow, some way. It's just a file format. People have been parsing files for a long time. So we just roll up our sleeves and we have a flexible platform that allows us to administer many different types of format parsing, many different types of protocols, and creates a queue of processing, an enterprise service bus of processing that allows us to process and interpret that data as we hit our application and put that data into a structured form in the application side.
And I want to emphasize that you're not just collecting quality metrics, which the student should know are relatively standardized at this point, but you're collecting clinical data from EMRs. And of course, by now the students have already seen that. They've seen some of the things you do. How do you normalize and standardize that clinical data when it comes from 200 different EMRs?
The key to that is being what we say purpose-driven. We don't try to boil the ocean and standardize every data point that we find in each document. We work with the provider organization to say, what are your clinical quality goals and how are you going to be paid based on this data? And we specifically look at all the file formats that they give us, and we pick out the pieces of data that relate to those clinical quality measures. And so that first simplifies the problem and allows us to really focus on data quality within that specific domain. Then we essentially maintain a dictionary of all code sets, and we have over 2.2 million mappings that we have curated over the past 8 years that relate the customer's custom dictionaries to all of the national standard dictionaries that exist out there.
Well, what about the patient in all of this? This is clinical data from their EMR. How do you manage the obvious privacy and security concerns?
Well, it's very important, and I actually respect a lot the High-Tech Act. When we've went into our first HIPAA risk assessment, you get pretty nervous, but as you go through it, you realize that it's a very healthy process. They have a long checklist of about 170-something regulations that as we went through it, we just made sure that we hit on each of those and that we're diligent and respectful. Internally to our organization, our people deal with clinical data all day long. They're helping our customers measure clinical quality. And so quite a bit of education within the company about how to handle that data responsibly is required.
So a patient like the make-believe multi-chronic disease patient, Marla, that we've created for this course, who's going to lots of different specialists, becomes a real challenge to know where is her record, who's caring for her, and how do you define quality in a patient like that?
Yeah, that's very, very tricky. So one of the biggest problems that Marla can pose is not going to the doctor at all. And how do you know if you're missing clinical data? Maybe you just don't have that interface. Maybe you don't have that relationship with that doctor that she went to see. And so I think what's happening right now is that provider organizations that are a single legal structure or entity, they're starting to solve this problem internally. And it goes to some other topics like the rollout of direct and the role of HIEs, is if you're solving this problem internally to that provider organization, that legal structure, how do the community structures that are outside of that organization participate?
Well, you mentioned direct, which is one of the technologies that I mentioned frequently here in the course. What do you see as the role of direct in this complex mix of doctors, patients, and quality metrics that you've laid out?
Wilsoniv is unique in that we're both an analytics and population health management clinical quality system, but we're also meaningful use certified. And we do that for a couple of reasons. One, because there's always a point of care aspect to clinical quality. But two, we have to play nicely with all of the standards that are out there with all of the core point of care EHRs. And so that means supporting direct and supporting standards like CCDA. The problem with the industry right now is that direct is a very flexible technology once set up. There's quite a bit of setup, quite a bit of administration to getting it set up. And what we're seeing is that internally to that provider organization that we were talking about, it's much easier just to bring the data in directly from the EMRs and not worry so much about the protocols and the directed aspect of direct, which means a provider can direct a chart to another provider. We see direct as really being more of the protocol for bringing data from external to that provider organization. From the HIE, and those structures are really just getting adopted by the communities and by the provider organizations today.
Well, one final question, and then I'll let you go. Put on your crystal ball glasses and tell us where you think we're going in the area of population health, quality measurement, and even outcome-based incentives.
Yeah, absolutely. This is a fascinating space. I'm very honored to be part of solving these problems in the industry. The most fundamental problem in the industry today is, again, saying how do we pay based on quality versus paying based on a fee-for-service action, a single action. And because the patient's a consumer and they can go to many different places, you end up having data that contributes to the quality spread across multiple systems. So you then have to bring that data together to really assess the total quality. In this comes a lot of deep questions about who is responsible for each of the quality actions, but also which record do I look at across these different EHRs or in the population health management system to determine that quality action was taken. The FTC has created clinical integration network guidelines that essentially say that a provider organization cannot contract with payers unless they are clinically integrated. And what that means is that the organization has to behave as one unit from a clinical quality perspective. They have to be following the same standards, processes, and procedures. That's easier said than done. And so workflows and health systems need to modify their internal structures and their internal investments over time to be able to even allow this workflow and the physician workflow to understand the entire spectrum of a longitudinal patient record. So what's happening there is that's getting refined. Once we achieve physician engagement in that process and we have high data quality, I then expect patient engagement and the empowerment of the consumer in healthcare to really flourish. I think it's going to stagnate until then, but after that I really see patient engagement taking off and putting the power of the power of the care, but also the incentives into the patient's hands.
Yeah, I couldn't agree more. I think the whole role of the patient and patient engagement just keeps becoming more and more prominent as time goes on.
Yes.
Well, I want to thank you again. You've not only
Absolutely.
given us an interesting technology story, which weaves in many of the themes of the course, but a great entrepreneurial story. Two guys having a drink, and now we have a major company in the population health space. So
Absolutely.
Thank you very much.
Thank you very much.